Total laparoscopic hysterectomy with dense bladder adhesions, lateral approach. The patient was a female of 43 years old, weight of 93 kgs, BMI 36.6. She had 2 children, both cesareans, and also 1 ectopic pregnancy treated. She had complaints of pelvic and bladder pressure with severe dysmenorrhea with heavy menstrual flow. She had tried Mirena coil, but it did not work for her. Ultrasound showed adenomyotic uterus of 14 cm and a 4 cm left ovarian cyst. Her hemoglobin was 10.6 grams. As you can see, the bladder adhesions are very dense. There is no space between the anterior abdominal wall, uterus and the bladder. So we start off with the right side. We are conserving the ovaries in this case. So we are doing the mesosalpingeal. We use the harmonic here and also the bipolar if necessary, taking the round ligaments. Coming now to the bladder peritoneum, the UE fold, trying to dissect from the lateral side. And then partly in the anteriorly we stay close to the uterus and dissect some of it. I have a cup in the vagina to delineate the vagina from the bladder, and we are skeletonizing the uterine. And now taking the uterine, coagulating it. Coming to the other side, we repeat the same thing. We are taking the ovarian ligament, conserving the ovary, mesosalpingeal pedicle, so the ovary is separated from the uterus. Tube is a bit stuck to the ovary. Now we have come to the lateral side here. Taking the round ligament, and trying to dissect the bladder through the lateral approach. Coming to a point where you can find a midline window anteriorly, but still you can see considerable amount of bladder is still stuck. Trying to delineate the vagina, taking the uterines on the left side. At this point, I have actually filled the bladder for me to delineate where the margin of the bladder is. I'm trying a little more to stay on the uterine side, leaving a little bit of uterine tissue onto the bladder rather than trying to find the perfect interface here, which could be quite difficult because it is quite thick and dense adhesions. And that's a good technique whenever any tissue that you don't want to damage is involved. You stay more towards the tissue you're taking out. So you can see that there isn't actually a plane at all. You can see the full bladder. So I'm leaving that bit of the tissue on the bladder. We got almost majority of the bladder away. Filling the bladder in such cases is very helpful so that you know to stay away from it. Okay. So we know now we're completely away from the bladder. Once the bladder is completely dissected, it's easier now to cut into the vagina with the cup in place. The last bit. And we are done. Checking the ureter here on the left side, which we are quite far off from the vaginal vault area where we were operating. The uterine on top of it.